SCPP is hosting this webinar for SCPP today. We acknowledge the land on which we live, work, and gather is Treaty 2, 4, 5, 6, 8, and 10 territory, the traditional land of the Cree, Dakota, Lakota, Dene, Nakota, Saulteaux, and homeland of the Métis Nation. The learning objectives today. So by the end of this, we hope to facilitate working knowledge of the Level 1 prescribing authority, to distinguish between billing and scope of practice, and to distinguish prescribing versus dispensing versus administration by injection versus laboratory practices. Today, the presentation will be conducted by the Policy and Legislation Unit at SCPP. Start with Kathleen Hanford, the Director, Natalie Rediger, Pharmacy Policy and Practice Consultant, and David Chow, another Pharmacy Policy and Practice Consultant. The three presenters today have no disclosures to report. And I will pass it over to Kathleen now to start the presentation.
Great, thank you, Danielle. So I'd like to welcome everyone here today to the second phase of our launching of the Level 1 Prescribing Authority. So today we will answer questions at a very high level. We've received over 350 questions to date, so I'd like to thank you all for that. We have done our level best to answer those questions through the presentation, several handouts, and also we have presented scenarios that we can walk through at the end, time permitting, or if that is a request. So just a disclaimer, these questions will be answered at a very high level. Of course, the devil is in the detail, and they don't replace all the specific details that could occur in a specific situation, as well as the bylaws and reference manual documents on prescribing authority. So the prescribing authority documents must be reviewed in full detail, and again, if you find that the high-level answers seem to contradict the specifics of your situation, then I invite you to look at the bylaws and those policy documents just to see what may have been missed. In those cases, the bylaws and policies prevail. If we run out of time today, as Danielle said, we have 1 hour. You are welcome to send additional questions to the SCPP for a response. I know the U of S folks will be sending the unanswered questions to us as well. We just ask that if you're sending additional questions that you take a look at the SCPP website, the general provisions and other reference documents, the webinars. This will be the second one. We have a December webinar that I invite you to watch repeatedly if it helps to give an overview, as well as the handouts today will remain available. What you will not get in the presentation today is detailed information on Level 2 prescribing authority. There is some information in the handouts on the application in the public institutions, the Cancer Agency and the Health Authority. However, more information is coming at a later date. This presentation will not address billing for professional services. The SCPP has been advised by the drug plan that all policies and billing processes for currently available prescribing authority services remain status quo at this time. And the drug plan will communicate with the pharmacies directly should there be any updates to the policies and processes in the future. And finally, the questions regarding funding of new pharmacy professional services related to the expanded scope of practice for pharmacists should be directed to the Pharmacy Association of Saskatchewan. Next slide, please. And I'll turn it over to Natalie.
Thank you. We'll start the presentation with the most common questions off the top. We all know that PIP data entry allows pharmacists and other health professionals viewing PIP and EHR Viewer to easily recognize when the original prescription was issued by the practitioner or the pharmacist. A common question was around using the PIP Graphical User Interface, or PIP GUI system, to create the prescription. And as part of this, typing in the pharmacist's reason for prescribing in the SIG instructions field of the prescribing function in the PIP GUI. So as noted in the revised Appendix B in General Provisions document, when creating a prescription using the PIP GUI, the information typed into the SIG field does not show up on the dispensing label. The SCPP recognizes that most pharmacists will generate the prescription in the pharmacy or public institutions vendor software, and is working with the Ministry of Health and eHealth to ensure that the updated prescribing activities are reflected in the vendor software. Next slide.
So we've received 3 general types of questions regarding billing and coverage, and the one you see on the screen is on administrative prescribing for private and public coverage. Now, the wording in the administrative prescribing category document was clarified to describe what is meant by third-party coverage, and again, that is public and private coverage. What you see on the screen is a typical question that we've received is, does this apply to initiating a prescription for over-the-counter medications for patients with Saskatchewan Health coverage, NAHB coverage, and or private insurance? And the answer is yes. In all situations, the drug coverage benefits will be subject to the patient's private or public coverage program, and the pharmacist should work with the patients to confirm their individual eligibility for coverage. And that you will find that in policy 2.3 in the level 1 document called Pharmacist Initiated. Next slide, please. We've received an assorted number of questions in this category, in addition to the one just shared, and they are included in the inquiry sheet. We have 39 pages of question and answers that we hope will help you navigate this launch. Some of the themes, though, there's many different questions, but some of the answers or the themes that we've found actually relate to what you see on the screen. And really things to keep in mind is that drug coverage benefits will be subject to the patient's private or public coverage program. The scope of practice changes do not determine what public or private benefits that patient gets. Part K does not apply to prescribing natural health products such as vitamins and minerals. It's simply for Schedule 2, 3, and unscheduled drugs. However, if you find yourself in a situation where you're selling or recommending, other medications, you may find the NAPRA SCPP supplemental standards of practice for Schedule 2 and 3 drugs helpful. It's just got some very good information that guides people through. And again, pharmacists should work with the patients to confirm their individual eligibility for coverage in all those situations. Next slide, please. So before Natalie takes you through some of the other questions regarding prescribing events, I would like to give you a bit of a history on back-to-back prescribing. One of the comments that we saw a few times in there is, why are we not able to prescribe back-to-back? So an interim supply and so forth. And the sentiment was that we could do that before. We're, taking a bit of a step backwards. So I just wanted to walk you through a little bit of history for context for the slides to come. So back-to-back pharmacist prescribing has not been permitted since prescribing authority was first introduced in 2011. However, in 2019, there were bylaw amendments that were put in place that did permit back-to-back prescribing in select circumstances. However, to do that, it needed to be enacted by the registrar. And that's the category called emergency exemptions in extraordinary circumstances. We discussed that in the December webinar as well. So to recall, that prescribing category, it's a discrete category with its own rules. It's tailored to address the needs of the situation. It's neither level 1 or level 2 prescribing authority. And by definition, given that it's extraordinary, it should be used in very rare circumstances, and the prescribing will be time limited. You just need to know it exists. Of course, the past 4 years when we introduced this, we have been living in extraordinary circumstances. So for many people, it might feel like common day. It still isn't. When the emergency exemptions have been enacted, you will see them listed, and I've got it in red on the screen. You will see that enacted. The SCP will communicate that, and we also document those emergency exemptions in force at the time in the Community Pharmacy Practice Enactments document, and you'll find that in the reference manual. In 2023, however, we've amended the bylaws, and so those exemptions will not be needed as often. So next slide, and I'll walk you through some of those situations. So again, back-to-back depends on the prescribing activity and the specific scenario. Again, this is high-level information, and it's very important to read the bylaws and the policy documents for more details. So in some cases, some of the prescribing must be done in a certain order, or the pharmacist may face a conflict of interest situation. So you'll see, for example, on the right-hand side, back-to-back is permitted, interim supply and emergency supply. And that one in particular, in situations where the emergency supply has a higher fee for prescribing, again, we still want the pharmacist to use that interim supply before moving forward. So just to share what's on here, back-to-back is not permitted. In back-to-back interim supply is not permitted, and back-to-back emergency supplies are not permitted. On the right-hand side, back-to-back prescribing is permitted with interim supply followed by emergency supply. If the pharmacist has prescribed insufficient information and then another pharmacist or the same pharmacist follows up with interim supply, that's acceptable. A dosage form adjustment followed by interim supply is allowed. Administrative prescribing followed by interim supply is allowed. Now, minor ailments is a very specific category. It's on its own, as it is more of a structured prescribing, and the back-to-back prescribing is permitted if it is done in accordance with the current MedSask guidelines and protocols. Next slide, please.
So now switching back to some of the submitted questions, a very common question was around interim supply quantity limits and back-to-back prescribing. Here was one of them. For interim supply of 3 months, can we provide 1 month with 2 refills? Does this consider back-to-back prescribing? The answer is that prescribing 1 month with 2 refills is permitted and does not constitute back-to-back prescribing. It may help to remember that it is the prescribing pharmacist that determines the quantity on the prescription based on their clinical assessment of the patient and the conditions and limitations outlined in Part K of the bylaws. Whereas it is the dispensing pharmacist that will determine how that quantity on the prescription is to be filled or dispensed to the patient. Next slide, please. So many of the interim supply quantity limit back-to-back questions also had a billing component to the question. We will use this one as an example. Question is, can you please clarify the up to 3 months interim supply but can't be back-to-back pharmacist prescribing unless it is an emergency supply followed interim supply? Does this mean that I can prescribe an interim supply of 1 month with 2 refills for a total duration of 3 months and dispense one at a time with a dispensing fee each time, but can only bill the interim supply fee to SPDP once? Or does it mean that I have to prescribe and fill 3 months at once for 1 dispensing fee and 1 interim supply fee? So interim supply prescription of 1 month with 2 refills is 1 prescribing event. And dispensing fee billing does not equal prescribing authority fee, such as the interim supply fee. One other note, the dispensing scope of practice does not equal the prescribing scope of practice. and SCPP has been advised by the drug plan that all policies and billing processes for currently available prescribing authority services remain status quo at this time, and the drug plan will communicate directly with pharmacies should there be any updates to the policies and processes in the future. Next slide, please. Oh, I think we might have missed a slide. Can we go back one? Okay, thank you. So this is similar to the question on the last slide, and this one highlights billing questions for an emergency slide. So question is, there was an example where a 1-month interim supply was provided followed by a 5-month emergency supply. In this situation, do you bill one fee for your 5-month emergency supply and fill each month as required? You can't dispense 5 months in one fill. So the answer, emergency supply of prescription of 5 months is one prescribing event. And similar to the themes on the previous slide, dispensing fee billing does not equal the prescribing authority fee, and dispensing scope of practice does not equal the prescribing scope of practice. Next slide, please. So there were a few questions that requested clarity on back-to-back and quantity limits for the interim and emergency prescribing interplay. For example, the question, is only one interim supply allowed of any length before having to move to emergency supply? Yes. For example, if a 2-month interim supply is provided by a pharmacist, can a 1-month interim supply be provided before having to turn to an emergency supply? No. So for the answer regarding an interim supply plus emergency supply back-to-back, a total of 6 months maximum is allowed, but depending on how you manage each individual patient scenario, it could be less than that based on what is needed for the patient and the situation. 6 months was put in place to ensure time for a patient to see or find a practitioner and to put up safeguards to prevent continuous prescribing for those patients who do not follow up with practitioners. Next slide, please. So another question on the theme of interim and emergency supply interplay. The question, how does a 5-month emergency supply protect patients more than a 3-month interim supply? Each level 1 prescribing activity is intended to address a specific patient situation while managing risks to the patients. No one type of prescribing activity is intended to protect patients more than another. Pharmacists must use their professional judgment to determine that which meets the patient's needs in a given situation. Next slide, please.
So this takes us to another common question that was in the Q&As that you'll see in the handouts. Folks were asking what happens when a family physician has moved away or stopped practicing. And one of the places where we looked for some of the immediate answers is using the dispensing authority or dispensing scope of practice as opposed to the prescribing authority. So we know that a prescription is valid for 1 year and therefore the dispensing options may still be available before using the prescribing authority to address the situation. Again, professional judgment is needed when serving patients with no primary care practitioner, and you'll find guidance in the general provisions document as well as the other reference documents pertaining to each prescribing activity. And just as a reminder on the slide, the relationship, another kind of mindset that we thought where people were kind of getting stuck was just what does it mean to have an active patient-practitioner relationship. So as someone had noted in the inquiries, is that relationship is defined quite broadly. So it's a relationship between a patient and a licensed pharmacist or a practitioner in which a professional service is provided for the purposes of optimizing the patient's health or drug therapy. And just a reminder as well, in the Prescription Drug Act, a prescription is an authorization given by a practitioner directing that a stated amount of any drug or mixture of drugs specified in it be dispensed for the person named in the authorization. So when you have a prescription, that is actually the result of an active patient-practitioner relationship. And that doesn't have to be a family physician or a primary care provider. It may be the patient's primary care provider. It may be family physicians, nurse practitioners, but it also may be practitioners working in emergency rooms, walk-in clinics, or other practice settings. So again, just a reminder that there's still the dispensing scope of practice available in those scenarios. Next slide, please. And although we know that the pharmacists are dedicated to serving patients, and we could see that in some of the questions coming through, we just need to remember that pharmacists are not trained to be the most responsible health provider, nor do they have access to the health system privileges that are required to be the most responsible provider. So these provisions are just as much to protect the pharmacist as it is to protect the patient. Next slide, please. Another theme that came up a few times, and we've heard this in the past as well, is about professional judgment. And actually the bylaws contain a clause on professional judgment, just that the pharmacist must have reasonably satisfied themselves that the prescribing decision is appropriate in the circumstances based on their assessment of the patient, and that prescribing decision is proper in the judgment of the pharmacist. Now, previously, the way the bylaws were, there were more limited opportunities for the pharmacist to apply their professional judgment. However, with the expanded authority, pharmacists will be facing more situations where they'll need to use professional judgment to determine which prescribing authority they can use in that situation. On the right-hand side are just some common examples that you will see in the slides, and examples of where, again, professional judgment is needed. So, for example, in interim supply, what is the quantity sufficient for the patient until the date of their next practitioner appointment? So the pharmacist will be thinking of many different factors. Emergency supply, what's the quantity of drugs sufficient to meet the reasonable needs of the patient where an interruption in therapy would result in imminent harm? Another question we get is the patient is chronic and stabilized on a drug. I know previously it was typically there was a period of time specified, and we're moving away from that with the hopes that, again, this can be used for the good of patient care, and that this judgment will be used prudently. We've also got reasonable attempts to contact the prescriber before altering or continuing prescriptions issued by a practitioner. So when you read these, the general provisions and the other documents, you'll see mentioned throughout that pharmacists are to use their dispensing scope of practice first before prescribing, simply because when you receive a prescription, that is an authorization given by another practitioner. That is not the practitioner authorizing the pharmacist to alter or continue the prescription. So we are really reinforcing the dispensing scope of practice as well as a strong foundation for the prescribing. Again, we mentioned patients with no primary practitioners, so knowing where to refer them. And also we often get questions around emergency situations when someone is having an obvious asthma attack or a diabetic and another health professional is not readily available. Again, what is needed in the time is professional judgment. Again, there are further examples of these themes in the handouts provided. Next slide, please.
So we've seen lots of examples earlier where illustrated that prescribing does not equal dispensing. So thinking of them as very discrete practices. And then we've also received some questions that confuse prescribing drugs, which is under Part K, with administering drugs by injection, and that authority is under Part L of the bylaws. And so, for example, one question asked, is giving flu and COVID vaccines considered to be administrative prescribed? No administering publicly funded vaccines are under the authority of Part L bylaws, and that is the administration of drugs by injection and other routes. And then the second question that you see here on this slide is an illustration of a question that touches on 3 discrete scopes of practice. Part K, prescribing drugs, Part L, administering drugs, and Part M, laboratory tests. And so we're hoping that by this you kind of take away some helpful ways to navigate the legal requirements of each of these discrete scopes of practice. So instead of using words like give or provide, it will be helpful for you to speak about the distinct scopes of practice by using the verb associated with them. So for example, are you dispensing or are you prescribing? If you're prescribing, you will look to Part K of the bylaws. If you're administering, you'll look to Part L of the bylaws. And so then again, just kind of having that takeaway of knowing where to look for the distinct scopes of practice and to use whether you're prescribing separately from whether you are dispensing. Next slide.
So this is a rather busy slide, but it's actually one of the last slides. And I just wanted to show you where you can look for information from the SCPP website. So if you'll see up on the top left-hand corner, there's a yellow text box mentioned scopes of practice update. If you click on that link on the home page, then you'll get the screen that's in the bottom right called Scope of Practice Updates. And again, we get a lot of questions, and it's we're saying the same answer. So that definitely is a place where you can go so that you are up to date on the Scope of Practice Updates. There's tabs at the bottom that are communications and announcements, that sort of thing, which again is a go-to place when you have questions or are trying to figure out what's happening and when. As you'll note on the page as well, that the pharmacist's scope of practice is status quo until the council-approved policies, competencies, and training are established and have been officially communicated to members. Contrary to what some may think, this is a huge practice change. It's a huge change for the system, and there's a lot of work that occurs on many different fronts with many stakeholders to implement this successfully. And I can see some of the questions or some of the outstanding pieces that still need to be put in place. But for your information, there are no immediate changes as a result of the bylaws, so everything is status quo until otherwise communicated by the college. So for example, some of the questions that came in were on level 2 prescribing authority. What do we do for vaccine preventable diseases, travel health, A and B? That one has been rebranded, and again, it's status quo for now. So again, we would invite you to look at the training and development webpage, the reference manual documents on that subject matter, and that's what we are doing to manage the interim until the expanded scope can be implemented as is. Also, there are some, we've addressed other disease categories as well in here. Those are in effect. You'll notice those on the community practice enhancement pages. There's Paxlovid prescribing, RSV prescribing. Again, we've answered questions in the inquiries document on that front. And finally, the advanced A and B prescribing as well as the laboratory practices are yet to be implemented. So just stay tuned.